Good afternoon, everyone. Welcome to the Research Committee meeting of Kwong Wah Hospital. Today, I want to present to you my work, Clinical Audit on the Preoperative Pain Management Quality and Practice in Kwong Wah Hospital. I did this work with my colleague, Dr. Tom Chen, and consultant Dr. Law. So, what is pain? As a doctor, I'm sure we hear patient complaining pain on a daily basis, but do we have a more accurate description or definition on it? Actually, yes. About 40 years ago, that was the first description or definition of pain. That is an unpleasant sensory and emotional experience associated with actual potential tissue damage, or described in such a term. Now, 40 years on, there is actually a new definition on it with some revised points. Although they look very similar, the two definitions, actually there are some points I would like to go through with you. Okay, so here are the revised points. Okay, so first of which is pain is always a personal experience. So the thing that I find painful may not be so painful to you or vice versa, okay? So we have to respect each other on their own experience. Pain and nociception are different. So nociception is more of a physiological parameter, but pain is more of an experience. It's a very personal, individualized experience. So although pain is an adaptive role, it actually has multiple physiological and psychological impact that it can brought about. So through different life experience, each individual may perceive pain differently. So a very classic example is that if a patient was admitted to hospital and we try to put a venous catheter for him or her, but then we fail for 10 times, then the next time he was admitted to hospital and the catheter needed to be placed, he'll be very scared and the whole experience will be much more painful than the first time. Okay, lastly, we have to look after a certain group of population because, say, pediatric patient, non-communicable patient, elderly patient with dementia, or mentally incompetent patient or disadvantaged patient has to be considered, and the pain assessment for them can be more challenging. So why is postoperative pain control so important? Reason being very simple is that it will affect the recovery and rehabilitation of the patient. So a very classic example is the patient coming in, going for general elective surgery. So the patient under GA, the OT was successful, the patient sent to ward, but then the patient experienced devastating pain, surgical pain, okay? So he could not sleep, he could not eat, he could not sleep well. So imagine, will it affect the rehabilitation of the patient? Will the patient be very satisfied after the operation, even though it's a successful operation? So the answer, of course, is no. You should be reminded that a very poor postoperative pain control is an individual risk factor for development of chronic post-surgical pain, which can be very debilitating in the person's life. So he or she may require long-term pain management or require long-term analgesics use. So let's talk about the background. Why are we doing this? Because we want to reintroduce the nurse-led discharge protocol. Okay, so imagine if our patients are always very painful and require the attendance of anesthetist. So the nurse in the PACU on the post-anesthetic care unit will not be able to discharge the patient to the general ward, which will greatly affect our clinical service. So the aim of our study is very simple. We want to know how we're doing, how good or how bad we are doing, okay? So I will present to you the data very soon. So yes, and the second thing we want to look at is the practice of each individual anesthetist, okay? So we want to know, are we using adequate analgesics? Are we carrying out enough regional technique, okay? So very quickly to go through our methods. So this is a cross-sectional retrospective clinical audit. We have recruited or we have looked at 251 patients who received elective general anesthesia under general elective surgery, okay? There were 9 subspecialties involved, which I'll be presenting to you later, and we'll assess each of their pain score of each individual patient, and we will present to you with descriptive statistics. So I know some of you may not be in the surgical stream or may not be an anesthetist. So I want to go through the very basic logistic for a patient undergoing elective surgery. So after the surgery has been finished, the patient will be transferred to the post-anesthetic care unit, or the PACU. He or she will be staying for at least 30 minutes. Okay, so that is where our pain assessment will be carrying out. Okay, so pain assessment carrying out here. If everything is satisfactory, the patient will be discharged to the parental ward, or if the ICU if necessary. So the pain assessment will be carried for at least 3 times. That is, right after the patient has been arrived, and at every 15-minute interval, all the way until the patient is discharged. Okay, so 3 times. And the data will be manually collected. So it was manually collected by me with our electronic medical record system. Okay, so every data is will be audited and will be presented to you later. So how is pain actually quantified, and how is pain assessed? So there are actually quite a number of tools that is available, but what we have used is a verbal descriptor scale. So verbal descriptor scale is to ask the patient the intensity of pain with a descriptor. So in English, it will be new, mild, moderate, or severe. Okay. So in Cantonese, it will be 冇痛、少少痛、中等痛, or 好痛. Okay. So four of them. Okay. So each will represent a different number, okay? So we will further stratify the patient into 2 groups. One is a satisfactory group, that is group 1, and the suboptimal group is a group 2. So any patient who complained of more than any one episode of moderate or severe pain will be stratified, or will be put into group 2. That is the suboptimal group. So in group 1, all patients enjoy only no pain at all, or just mild pain. Okay, so all patients are over the age of 16 undergoing general elective surgery. Okay, so we have excluded some patients, okay, that is the minor under 16, patient who are unable to express themselves freely, patient who underwent unanticipated J conversion. So what is unanticipated J conversion? I'll give you an example. Is that the patient was planned to undergo the surgery under a regional technique or a spinal anesthesia, but then somehow maybe this OT is very long, or maybe the patient still complain of pain, then we will convert it to GA. So in these cases, we will not be including these cases, because that regional technique or that spinal anesthesia may actually be interfering our results. So it will not be a wise decision to include them. So in complete clinical data, of course, we are unable to proceed the data, so we are not including that. So as for the participant, we have 251 valid patients. The surgery included were between the period of September to November last year. So yes, these are the demographics of the patient, and I'll be presenting to you in a more in a descriptive statistical method later on. So yes, 251 patient, more female than male. Average age is about 62.8. Okay. So these are the 9 subspecialties that were included in this clinical audit. Okay, so it can be seen that the breast team has the most cases of 56 cases, and upper GI team has the least number of cases, only 6 cases. So here we can see, out of 251 patients, only 19 of them complained of or were reported to have suboptimal pain control, which means that 92% of them enjoy a satisfactory pain control, okay? And these are the percentage of number of patients that were reported to have poor pain control, say out of 19 patients, okay, so 32% of which were belong to the HBP team, okay? So the urology team will be 21%, upper GI team will be 11%. Okay, taking a different perspective, okay? So we can see that breast team has the most patient, but then none of them were reported to have suboptimal pain control. So all breast surgery patients were enjoying good pain control. Well, as for upper GI team, although they only have 6 patients, but 2 of them actually were reported to have suboptimal pain control, and that made up to about 33%. Yes, so yes, GI team 33%, and say other team, plastic team just 2%. And these are the numbers of each subspecialty, surgical subspecialty pain incidents. Okay, so I don't know if you have heard of multimodal analgesia, but it's a very common term in the field of anesthesia and in pain medicine, and is getting ever more popular. But what is it? What is multimodal analgesia, or MMA? So multimodal analgesia is the use of more than one single pharmacological class of analgesics. So I'll give you an example. The most common example would be the patient receive opioid, say fentanyl or morphine, and then we give an extra analgesic, say paracetamol or NSAID to the patient. So I can say that my patient has received a multimodal analgesia because he received paracetamol and opioid. Okay, so although it's generally agreed that MMA is very useful, but as regards to which drug to use for which type of surgery, then we don't have a solid or high level of evidence so far. Okay, so let's look at it. So about 64% of patients, 64.9% of patients actually receive analgesics, more than one type of analgesic. So more than 64% of patients has received an MMA. And then 80% of which has received 2 kinds, and another 14% of which receive up to 3 kinds of analgesic agents. So yes, this is a type of patients that we'll be looking at, okay, later on, especially of their pain control. Will they be having a better pain control, or will they be enjoying a poorer pain control? Okay, yes, so single analgesics is not MMA, right? So no, they are not. These are, yes, 2 analgesics or above. So no patient received more than excuse me, more than 3 analgesics so far, okay? So only 2 and 3. Okay, so yes, I did not specifically write down, or I did not specifically say opioid, because all our cases has received at least one type of opioid, that is either fentanyl or morphine. So fentanyl is used very commonly in general anesthesia because it is mainly used to obtune the airway reflexes during the airway maneuver, okay? And morphine is more commonly used as an intraoperative or postoperative potent analgesics. Yes, so these are the 2 types of opioid that we use very commonly, okay? Okay, let's look at the frequency of prescription for each drug. Okay, so it can be seen that paracetamol is the most popular analgesic. Okay, it has a most frequently prescribed. Okay, as compared to second runner up, that is the NSAID, as we can see. Okay, Other including IV lignocaine, IV dexmedetomidine, and IV ketamine, okay? They are pretty rarely used comparing to these two. And regional technique, okay? So what is regional technique? I'll give a very brief introduction to regional technique. For regional technique, it can be used solely for the procedure, but in here we are talking about on top of the general anesthesia. So the regional technique is mainly for intraoperative and postoperative analgesia, pain control, but not serving as an sole mode of anesthesia, okay? Mainly is for analgesia. So 19 regional technique or 19 cases of RA was carried out among all the patients, okay? The most used ones are transversus abdominis plane block. We always use this, we almost mainly use this for patient with large surgical scar on the abdominal wall, say laparotomy, okay? Very commonly used. Others include inguinal block, the QL block or the quadratus lumborum block, rectus sheath block, and so on, okay? But they are rarely, less frequently practiced as compared to the TAP block. Okay, so these are the results I'll be talking to you. So 77.6% of cases experience suboptimal pain control, which means that up to 92% of patients actually enjoy a good pain control, okay? Up to 92% of patients, okay? Multimodal analgesia were carried out in over 64% of patients, okay? Regional technique, not a very high number, but we have to understand that by carrying out regional technique, we have to choose the right patient and the right procedure. So it has to be clinically indicated, and we will usually balance the risk and benefit for each patient before offering or carrying out a regional technique. As mentioned, upper GI and HBP surgeries are the most painful ones. It should be mentioned that orthopedic surgery were not included in this clinical audit, okay? So just general elective surgery. Okay, so let's move to the discussion, okay? Let's move to discussion. Okay, as mentioned, upper GI and HBP has a high proportion of poor postoperative pain control. And we have also noticed that as anesthetists, the anesthetists are more likely or more intended to perform regional technique or on these cases, okay, because of the evidence, of high level of evidence showing that these group of patients are most prone to post-operative pain. So these are the gender distribution of our patients. So it can be seen that they're more female than male. But why is this important? Why is gender distribution of our concern? It is because evidence have shown that female patients are more likely to experience poor postoperative pain control as compared to male patients. And in this clinical audit, the results are actually in contrary to that, okay? In both male and female groups, the suboptimal pain control were at about 7% and 7.2%. So then actually not clinically or statistically significant in this respect. Again, here I'll discuss with you paracetamol. Okay, we often use paracetamol. It's been used very frequently, as you can see. But how are we going to give it, and what formulation are we giving it? Okay, so what route are we giving it? So do we give it IV or do we give it per oral? Actually, recent evidence show that there is no difference. Okay, no difference. So oral is as good as IV. Okay, but of course, in a clinical setting, if the patient is under general anesthesia, we have no choice and left us no choice, but we'll give it IV. Another option will be giving it before the OT, okay, before, say, on call to OT. So the patient will be given oral paracetamol before entering the OT. The advantage of giving per oral paracetamol is that, first of all, it's more economical. The price is much less. Secondly, is that it produces less plastic waste. That is carbon footprint. So we give a more greener anesthesia. Okay, the second most used analgesics are non-steroidal anti-inflammatory drug. Okay, so NSAID, but it is much less commonly used or much less commonly given to our patient. The main consideration as a frontline anesthetist is that they carry multiple side effects that is of our concern. Let's move to that. First of which is renal impairment. Okay, the most feared side effects, and secondly are the cardiovascular risk. So in a clinical setting, especially in patient undergoing ultra major surgery with anastomosis, with high risk of bleeding, we very often we'll discuss with surgeon, and we will need a consensus before prescribing NSAID. So I think it's one of the reasons which give anesthetists and hesitation before when they give it. Okay, so and it can probably explain why this is much less prescribed in here in a slide 25. Okay, it's much less than paracetamol. Okay, so we have observed a paradox on pain control. It can be seen that there's a paradoxical increase in incidence of postoperative pain in patients who received MMA or regional anesthesia. So why is that? And I think the main reason is that we have, as an anesthetist, we have selected the cases that are most likely to have poor pain control and to do the most for them. So say for upper GI cases, we will actively consider regional technique. We'll actively consider giving all the available analgesic for them because we can imagine that they will be painful, okay? So this is a very common scenario as a frontline anesthetist. So the nurse call you up and tell you that the patient is in pain. So what do we normally do when we were informed that the patient is in pain? So of course we have to attend the patient, but do we give analgesic immediately? The answer is no. We will need to assess the patient. We will need to rule out other more important differential diagnoses, say surgical or medical emergency. So commonly we'll go through the vitals, we'll talk to the patient, look at the mental state, we'll look at the surgical site to see if there's any bleeding or other surgical emergency. We'll do some bedside investigation if necessary. And after ruling out all the emergency, we'll arrive to the conclusion, before we can arrive to the conclusion that the patient is okay, the patient is in pain. So we'll consider giving them a rescue medication. So the most commonly used rescue analgesics is the morphine or the morphine protocol that we are currently using right now. So the morphine protocol in here, we can see that the dose is 1.5 mg of morphine every 10 minutes for up to 3 doses. So we put a sticker here and we prescribe it. The nurse are entitled, so the nurse can give the morphine to the patient by this description, okay? So this is a morphine protocol and it can allow the nurse to do it without the anesthetist coming out from the theater to the recovery ward every time just to give a single dose of morphine. So this is another interesting observation here. So in the orange line, this is the painful group, okay? The group 2, okay? So this is the average or mean pain score of the painfuls of suboptimal pain control group. And the y and the x-axis is the time after the arrival. So, which means that after they arrive, this painful patient, actually the pain score will decrease, will drop, and all the way upon the discharge, basically that's the pain is settled. Okay, the pain is already settled. That is between mild, is just about 1.11. That is about very near to mild pain. And for the patient with good pain control initially, the pain score has shown a slight increase. So why is that? So so what we think is that due to the morphine protocol or the help of morphine protocol or or other rescue analgesics, these patients are very likely to receive these analgesics after they arrive because they are painful, so their pain score will drop. And as for the patient with good pain control, obviously they don't require any of those, but due to the wearing off of the general anesthetics, say the volatile agent or if it is TIVA, that would be the propofol or any induction agent, they will regain the consciousness. Okay, so their pain score will have a slight increase, but this is only our postulation. Okay. Yes, this is what I've just said. So let's look at the strength of a study. First of which, our strength have an adequate sample size of over 250 patients. We don't have a lot of cases selection, as I've mentioned to you. Basically, little or no predetermined criteria. A wide range of GA cases across 9 subspecialties over a period of 3 months, okay? And a very standardized pain assessment tool, the verbal descriptor scale, was used, okay? So to standardize the pain assessment. But of course, we have our limitation. The first of which is the pain triggering event near the time of pain assessment. A very classic example will be turning the patient or moving the patient or shifting the surgical drain. So if we do this pain triggering event near the time of the pain assessment, the pain obviously is higher, okay? The pain is obviously will be intensified. Secondly, is the subjective interpretation of the patient description. Say sometimes the patient may not be able to answer exactly the way you ask him or her. I'll give you an example in Cantonese. So if you ask the patient if it is 小痛、中痛、大痛, the patient, an elderly patient may answer to you 有啲 or 唔算太多, but that will leave the nurse to determine whether this is mild pain, moderate pain, or even severe pain. Interview pain assessment, as I've mentioned to you, the pain assessment will be done every 15 minutes. But sometimes nurses are very busy, they have clinical work to do, they have to look after different patients. So the timing of the pain assessment may not be highly accurate. Okay, so this is the conclusion of clinical study. So 92%, 92.4% of patients actually enjoy good pain controls post-operatively, okay? 64% of patients receive more than one type of analgesics, okay? As for regional technique, as I mentioned, it actually very much rely on the anesthetist decision and whether the case is suitable to receive regional technique. So lastly, it should be say again that good pain control is not only about patient satisfaction, but it is also an important aspect in patient rehabilitation and in the overall recovery of the patient. So I think as an anesthetist, of course, is of our concern, but as a surgeon, I think it's also of the surgeon concern because it actually affects how the patient is recovered, right? So we welcome any questions. Thank you very much. Thank you.